So, good morning to all. Today we have lecture on hysteria and anxiety. There are two topics in this lecture. First, we will start with hysteria. The learning objectives are to explain what is meant by psychosomatic illness and describe somatic symptom illness and identify their three central features. Discuss the characteristic and dynamics of specific somatic symptom illness. Distinguish somatic symptom illness from factitious disorder and malingering. Discuss the etiologic theories related to somatic symptom illness. Apply the process to care of patient with somatic symptoms. Providing education to the patient, family, and community to increase the knowledge and understanding of somatic symptom disorders. Evaluate your feeling, beliefs, and attitude regarding client with somatic symptoms disorders. So let's start with introduction. The concept of hysteria is not new, but it is believed to have erupted in Egypt and is about 4,000 years old. The term hysteria refers to multiple physical complaints with no organic basis, which means the person have symptoms like pain and aches, but without any physical cause behind it, which is called as organic basis. The complaints are usually described dramatically. You will find the person is dramatic in describing their presentation. Later in the Middle Ages, hysteria was associated with witchcraft, demon, and sorcerers. Uh, and people with hysteria, usually women, were considered evil or possessed by the evil spirits. So the concept of hysteria evolved further, and it has got the scientific basis, in which the Paul Priquet and Jean-Martin Charcot, both French physicians, identified hysteria as disorder of nervous system. And along with the Charcot, Sigmund Freud observed that the people of hysteria improve with hypnosis and experience relief from physical symptoms when they are recalled memory and expressed emotions through the psychoanalysis. So this gave the idea that hysteria is not evil or possession of some sorcerers, but its basis has in the nervous system. So the basic theme of hysteria is proposed by Freud was the people can convert unexpressed emotions into physical symptoms. The process is known as somatization. Somatization is a word under which various disorders fall, and one of which is hysteria. And without understanding somatization, one will not be able to understand hysteria. So we will discuss somatization also. The concept of psychosomatic illness is it has three central features, in which the first one is it suggests major medical illness, but have no demonstrable organic basis. You will find no abnormality in the investigations in your physical examination, but the presentation is like that the person is having a serious medical illness. It has a factor of conflict, which conflict with the family member or others, which is important, may prove important in initiating the presentation, exacerbating the presentation, or maintenance of the symptom if the conflict is long lasting and continuous. The important thing is that the person somatization is not under the client's conscious control. This means that the person is not voluntarily presenting the symptoms. This is an unconscious process in which the person has no voluntary control. Now, talking about the nature of the illness, usually these people do not seek help from the mental health professional initially. Because the presentation is somatic and they feel like the person, they are having some kind of medical illnesses, they first go to the uh, medical health professionals, and ultimately they'll end up with the mental health professionals. And unfortunately, many healthcare professionals do not understand the nature of somatic symptom illness, so they are not much of sympathetic towards these clients' complaint. And therapists must remember that these clients really experience the symptoms they describe and cannot voluntarily control them. The person who is somatizing, actually they are experiencing the pain and other symptoms. Although the basis is not found organically or on the investigations, but do consider that the symptoms is actual for the person and real for the person. These are not in the voluntary control. They cannot let go those symptoms by their own wish. So in etiology, what are the psychosocial theories behind these somatization? The first thing is internalization and the second is somatization. Internalization means the person keeps the stress, anxiety and frustration inside uh, himself rather than expressing them outwardly to the others verbally or by other means. So this is internalization. This internalization externalized through the physical symptoms. These feelings uh, and stress are expressed through physical symptoms, which converts into somatization. So the people with the somatic symptom illness do not readily and directly express their feeling and emotions verbally. They indirectly express their feelings by virtue of physical symptoms like pain. So both internalization and somatization are unconscious defense mechanisms. The other features of these persons are they have tremendous difficulty dealing with the interpersonal conflict. They are not in the position to resolve their conflict with others. So they keep their stress and anxiety with them. And it is observed that when the person is placed in situation with which involves conflict or emotional stress, their physical symptoms appear to worsen. And when the person is placed outside to that situation, and sometimes we used to see in the uh, cases like when we admit those person in the ward, they get relieved of the conflict which is being in their house or in their immediate environment at home. So they feel relieved of the symptoms and their complaints are reduced. The one term is primary gains, which are the which is the direct internal benefit that the person gets uh, from the presentation of somatization. For example, if the person is having conflict with uh, their siblings, uh, then the primary gain is the internal benefit which is the person is having with their siblings are resolved or get away because of their presentation of symptoms. And the secondary gains are the which are not directly associated with the conflict, but it is additional benefit they used to get from the uh, role of being sick, like the tea is being brought at the bed and receiving a back rub, and not letting attend the school for child. So it is a secondary gain which the person may get during the course of illness. Okay. So in the long term, the person learns that he or she needs to be sick to have his or her emotional needs met. When this cycle begins, this vicious cycle begins, they usually learn that they need to be in the sick position to get the benefits. Yeah. So this is the learning behavior. The term hysteria is came from the Greek word which means wandering uterus, and the ancient theorists believe that the unexplained female pains resulted from migration of the uterus throughout the woman's body. This is the old theory which was some thousands of years old, because the hysteria was commonly seen in the females, so this was associated with the uh, term hyster. Hyster is known for uterus, and the term came hysteria from the hyster. But nowadays it is also the fact that this hysteria or conversion disorder may occur in males also. So other factors are for being prevalent in females, that for the boys it has to be said that uh, take it like a man for the stress. Uh, they have to be strong by the demanding society, and females usually seeks medical treatment more often. So, uh, it is found in females more, and childhood sexual abuse happens more frequently to the girls. So this may also be a reason to somatize. So abuse is also a kind of stress which may be expressed through the somatic symptoms. What the biological theory says, the biological theory says that these patients cannot sort relevant form of irrelevant stimuli and respond equally to the both types. In other words, the threshold of the uh, nervous system to recognize the abnormality like pain, abdominal pain or heat or too much of cold is reduced. So normal peristaltic movement may feel like a abnormal thing. So too little inhibition of sensory input amplifies the awareness of physical symptoms and exaggerates response to the bodily sensations. This is the biological theories. So what kind of disorders comes under somatic symptoms or somatization is somatic symptom disorder. The second is conversion or dissociative disorder, which previously known as hysteria. In somatic symptoms, there is one or more physical symptoms that have no organic basis, and individuals spend a lot of time and energy focused on health concern, and often believe that symptoms should be indicative of some serious illness, and experience significant distress and anxiety about their health. And what happens in conversion and dissociative disorder is uh, the symptoms which mimic like neurological disorders like blindness, paralysis, hemiparesis, or sensory loss, loss of motor functions, which mimic like neurological disorder, but the basis is not. Basis is psychological factors behind the presentation, which is called as conversion or dissociative disorder. So there are two terms, dissociative and conversion disorder. What does it mean? The dissociative disorder uh, cause a person to be disconnected from their thought, memories or consciousness and identity, which is not because of the neurological problem, and the person may present as amnesia, fugue and transient possession. In conversion disorder, the problem is mimic like neurological symptoms. For example, stupor, pseudo seizure, motor disorder, difficulty in walking, anesthesia, and sensory loss, uh, which are indicative of neurological problem, but the basis is not found on examination and investigation. The third one is somatic symptom disorder is pain disorder, in which the person primarily have symptoms of pain, which is generally unrelieved by analgesics and greatly affected by psychological factors. And the fourth one is illness anxiety disorder, formerly known as hypochondriasis, in which the person preoccupied with the thought that he is having some kind of serious illness. In this hypochondriasis, the person believes that and name some of the illness. He is not focused on the symptoms. He is actually focusing on the diagnosis. He may uh, he may come up with diagnosis of his physical symptoms. I am having, for example, I am having cancer, or I am having this disorder. I am having this disorder. So this happens in hypochondriasis. Now about the onset and clinical course of the somatization, and it is usually starts in adolescence, and diagnosis may not be made until early adulthood. It usually occurs between the age of 10 and 35 years. It may have a chronic or recurrent course of illness and may last for decades for many people. So, person who have learned the uh, how to deal with the stress in a different way, the picture may go last for decades. Usually, they seeks help from mental health professional after they have exhausted effort and finding a diagnosed medical condition. So, lot many papers and investigation they will have with them, and multiple consultation they have already made before reaching to a mental health professional. They usually tend to be pessimistic about the medical establishment because of the frustration. The medical establishment cannot diagnose his problem and cannot give them the relief. So they are bit pessimistic about the system and often believe that their disease could be diagnosed if providers were more competent. So they found them incompetent, but it is not the case. Now, how to assess the person with somatization? And history is important in assessing the person. They usually provide the person will usually provide a lengthy and detailed account of problem. Numerous diagnostic tests they may have with them, and even a number of surgical procedure may they have gone through. And it is likely that they have seen multiple healthcare providers over several years. They may express dismay or anger at the medical community. In general appearance and motor behavior, often they walk slowly or with an unusual gait in case of uh, conversion disorder, in which the person may have conversion motor disorder. They may exhibit a facial expression of discomfort or physical distress, and in many cases they brighten and look much better as the assessment interview begins because they have an interviewer's undivided attention. So when the person first time meet with the therapist, so they may look brightened or enthusiastic. Clients with the somatization disorder usually describe their complaints in colorful and exaggerated terms but often lack specific information. Their complaints will be very colorful and in a dramatic or exaggerated way, but if you want to find the specific information, they may not be able to give. Their mood is often labile, shifting from seeming depressed and sad when describing the physical problems, and to looking bright and elevated or excited when talking about how they had to go to the hospital in the middle of the night by ambulance. So this type of picture you may see with these persons. Emotions are often exaggerated, or as are reports of physical symptoms. They may describe a series of personal crises related to their physical health, may appear pleased rather than distressed about these situations. A patient mainly focus on physical problem. Patient with conversion disorder may display an unexpected lack of distress. So this is known as labile indifference, in which the person or seems to be in thought process. Usually they do not experience disordered thought of process. For example, any kind of formal thought disorder, or in content they won't have delusions, and in perception they won't have hallucinations. So the form of thought is maintained, they are relevant and coherent, and but they are preoccupied with their physical problems. They are unlikely to be able to think about or respond to question about emotional feelings. If you talk about the emotional feeling, they may not, and they will come up with the physical problems mainly. In illness anxiety disorder, uh, which is known as hypochondriasis, the person may focus on fear of serious illness. They come up with the name of the illness, and the person with hypochondriasis are preoccupied with bodily functions, ruminate about the illness, and fascinated with medical information, and have unrealistic fears about potential infection and prescription medications. So this thought process may found in the hypochondriasis. They are alert and oriented. Intellectual functionings are unimpaired, but in the judgment and insight, exaggerated response to their physical health may affect their judgment. They have little or no insight into the behavior. They are firmly convinced that problem is entirely physical and often believe others do not understand. So their judgment may be impaired because of their preoccupation. In other features, they are likely to be unemployed. They often lose jobs because of excessive absentees and inability to perform work. They may have quit working voluntarily because of the poor physical health, as they think that consumed with seeking medical care, they have difficulty fulfilling family roles. It is likely that they have few friends and spend little time in the social activities. So this kind of situation you may find with these patients. They may report a lack of family support and understanding, and also the family members of these patients may tire of the ceaseless complaints and their refusal to accept the absence of medical diagnosis. Maybe the problem of the family members of the patient, the illness and physical condition often interfere with planned family event such as going on vacation or attending family gatherings. So because of the person, other family members also suffers their social life. Home life is often chaotic and unpredictable. So in addition to these, the multitude of physical complaints, these patients often have legitimate needs in terms of their health practices. Those who somatize often have sleep pattern disturbances, lack basic nutrition and get no exercise. In addition, they may taking multiple prescription for pain and other complaints. So in the last, just because the patient has been diagnosed with somatic symptom illness and the therapist knows that there is no basis of physical ailment behind it, so their complaint should not be denied. He or she should be completely assessed because the client could at any time develop a physical condition requiring medical attention. So in between the therapy, one patient may complain of newer symptoms which should be assessed thoroughly and should not be left unassessed. The person may get into the trouble. So every new complaint should be addressed as if the person is having some problem. In intervention, what you can do is providing health teaching, help the client learn how to establish a daily routine, adequate nutritional intake, improved sleep pattern, and a realistic balanced daily activity should be instituted. And initially, therapists must experience resistance, including protest from the person, and the therapist should not attempt to confront the patient about somatic symptoms and or attempt to tell them that these symptoms are not real. So do not confront with this patient that you are not having any problem, you are not having any illness, uh, you have nothing and you are all right. Don't say these words and actualize the problem of the person as if it is real. Help them to express their emotions, and while doing therapy, teaching about the relationship between stress and physical symptom is useful way to help them begin to see the mind body relationship. So there is a mind body relationship. Mind read the subtle symptoms as if these are the bigger problems as per the biological theory. So mind body relationship should be taught to these persons. The therapist might ask them to describe the situation at the time, such as whether they were alone or with others, whether any disagreement were occurring, and so forth. So you should correlate their exaggerated symptoms or increased symptoms with the situation when these occurs with the conflict. And a diary may help patients see when physical symptoms seem worse or better, and what other factors may affect the perception. Encourage them to focus on emotional feeling is important, though this can be difficult for them. They are usually focused upon the physical symptoms, but realize them what is going behind the physical symptoms, what are the psychological factors are affecting uh, their health status. The therapist should provide attention and positive feedback for efforts to identify and discuss feelings. It may help for the therapist to explain to the family about primary and secondary gains and to stop reinforcing the sick role. So primary and secondary gain should be removed. Secondary gain should be removed to realize them that to enhancing their coping skills. So there are two type of coping strategies. One is emotion focused coping strategy, and the second one is problem focused coping strategies. Emotion focused help them relax and reduce the feeling of stress, and problem focused helps resolve or change their behavior or situation or to manage the life stressors. So many uh, approaches to stress relief are available for them to try. The therapist should help them learn and practice these techniques, emphasizing that their effectiveness usually improve with routine. Patient must not expect such a technique to eliminate their pain or physical symptoms. Rather, the focus is helping them manage to diminish the intensity of the symptoms. So, in short, uh, there are three interventions: health teaching, expression of emotional feelings, and coping strategies. So, for hysteria and somatization, the key points are somatization means transforming mental experiences and states into the bodily symptoms. Somatic symptom illness includes somatic symptom disorder, conversion disorder, illness anxiety disorder, and pain disorder. Internalization and somatization are the chief defense mechanisms seen in the person with somatoform disorders. Coping strategies that are helpful to the person with somatic symptoms. Person with somatic symptoms disorder actually experience symptoms and the associated discomfort and the pain. And the therapist should never try to confront the client. Somatic symptom illness are chronic and recurrent, so progress toward treatment outcome can be slow and difficult. So in the chapter of hysteria and anxiety, now we will discuss about the anxiety. So one must understand what is pathological anxiety. Anxiety is a normal phenomena, but how it becomes pathological and it warrants the medical attention. So anxiety is a vague feeling of dread or apprehension. It is a response to external or internal stimuli that can have behavioral, emotional, cognitive, and physical symptoms. So anxiety is distinguished from fear. Fear is a feeling of feeling afraid or threatened by the clearly identifiable external stimuli that represent danger to the person. So fear is a normal anxiety. For example, if some car is speeding towards you, you will become anxious and try to escape this situation. So this is fear. Anxiety is a vague feeling of dread or apprehension. The normal anxiety is unavoidable in life and can serve many positive functions such as motivating the person to take action to solve the problem. If you are anxious, then you will try to learn more to pass the examination. So some kind of anxiety is normal. To resolve a crisis, it is considered normal when it is appropriate to situation and dissipates when the situation has been resolved. Anxiety comes with a dangerous situation or situation which have to be dealt with, and it goes when the situation is not there or passes off. So this is normal anxiety. This is the model for stress performance connection. As the level of stress is increased, the performance is increased. When the level of stress is medium, When the level of stress is low, performance will also be low, and if the level of stress is very high, the performance is also very low. When there is moderate kind of anxiety, then the performance is increased. In low form of anxiety, one may not try to resolve the problem at all. This is the model for performance and level of stress. Anxiety disorder comprise a group of conditions that share a key feature of excessive anxiety with ensuing behavioral, emotional, cognitive, and physiological response. This is the definition of anxiety. And patients suffering from anxiety disorders can demonstrate unusual behavior such as panic without any apparent reason, unwarranted fear of object or life condition, unexplainable or overwhelming worries. They experience significant distress over time, and the disorder significantly impairs their daily routine, social lives, or occupational functioning. Anxiety as a response to stress. So, each person normally handles stress differently. One person can thrive in a situation that creates great stress for another. So, the perception of stress is different for different people. You know, and the situation may be handled by in a different way by the different peoples. Many people view public speaking as scary, for example, but for teachers and actors, it's an everyday enjoyable experience. If you are suddenly uh, led to the public speaking, then you will feel somewhat anxious and scary. But if it is used to for your profession, then it is not the case. Anxiety is low or none in such situation. And marriage, children, airplanes, snake, a new job, a new school, or leaving home are examples of stress causing stimuli. So situations which is depicted here may prove as stress causing stimuli, and one may be able to cope up with and one may not. The person who do not be able to cope up with these situations may end up with the anxiety disorders. So, in sign and symptoms of anxiety, there are three sets of symptoms. One is cognitive, the second one is biological, and third one is behavioral. How the person thinks is cognitive symptoms. These are the central symptoms. Dread and apprehension about the future the person have in their mind, or they may have a verbatim like, I will do something wrong in this situation, I will commit mistake, I cannot do this, who will help in these situations, other will recognize that I am frightened, feeling of impending heart attack, and anticipatory anxiety of having future panic attacks. So these are the thoughts which runs into the mind of a person with anxiety disorder. The bodily responses may be diarrhea, hyperhidrosis, hyperventilation, palpitations, restlessness, tingling, coldness, tremors, upset stomach, urinary frequency, hesitancy or urgency. These are the feature of bodily response to anxiety, which is also known as uh, autonomic hyperactivity, which you may have also experienced during your before your viva. The behavior one person can have, avoiding the stimuli, which is known as agoraphobia, relieving anxiety by performing rituals like compulsions. Mopping means dealing with your own anxiety in uh, when there is no one and you need to be in alone situation. Other behaviors may be unhealthy coping tools like substance abuse. The person may start abusing alcohol or other substance. Nervousness, shaking your leg up and down, which is known as fidgeting, touching your face, winking, blinking. These are the behavior which may be the part of anxiety. Thought behaviors are negative self-talk, feeling as though you are going crazy, convincing yourself something is wrong with you. The behavioral pattern for anxiety disorders. So there are three levels of anxiety in anxiety disorder. One is mild, moderate, and severe anxiety, and the fourth one is panic disorder. In mild anxiety, the person may feel that there something is wrong and warrants the special attention or medical attention. In moderate anxiety, the person becomes nervous or agitated. In moderate anxiety, the person can still process the information and solve the problems and learn new things with assistance from others. Person alone cannot do uh, these tasks. In severe anxiety and panic, more primitive survival skills take over, defensive response ensues, and cognitive skills decrease significantly. For example, in panicky situation, the emotional psychomotor realm predominates with the accompanying fight, flight, or freeze responses. Adrenaline surge greatly increases the vital signs, pupils enlarge, and the only cognitive process focuses on the person's defense. So this is panic attack. Now, how to work with the person with anxiety disorder? How to deal with these uh, patients? Teaching can be effective when the person is mildly anxious. Only reassuring the patient is the method to resolve the anxiety. With moderate anxiety, the therapist must certain that the client is following what the therapist is saying. The person's attention can wander, and one may find difficult concentrating over the time. And speaking in short, simple, and easy to understand sentences are effective in dealing with the moderate anxiety. And during the panicky anxiety, the therapist can reassure the person that this anxiety is temporary, it will pass. No, he or she is in the safe place, and the therapist should remain with the person until the panic recedes, and it usually lasts for 5 to 30 minutes. In anxiety disorder, the classification has disorders like agoraphobia, panic disorder, specific phobia, social anxiety disorders known as social phobia, generalized anxiety disorder. In incidences, the highest prevalence rate of all mental disorder is anxiety disorder. It is more prevalent in females and people with below the age of 45 years, people who are divorced or separated, people with low socioeconomic status are having more anxiety disorders. The onset and clinical course of anxiety disorder are extremely variable, and it depends on the specific disorder, which is disorder the person is having, like generalized anxiety disorder or specific phobia or social phobia. Now, the few words about the etiology. What the biological theory says, the genetic theory says that panic disorder, social anxiety, and specific phobias, including agoraphobia, have moderate heritability. Neurochemical theory says that the GABA is the amino acid neurotransmitter believed to be dysfunctional in anxiety disorder, which is uh, neuro inhibitory neurotransmitter, which controls the excitability of the neurons. In neurochemical theories, the other neurotransmitter which is involved is serotonin, and its type 1A plays a role in the anxiety. It also affects aggression and mood of the person. What the psychodynamic theory says, psychodynamic theory like intrapsychic or psychoanalytic theory says that defense mechanisms are cognitive distortions that a person uses unconsciously to maintain a sense of being in control of the situation and to lessen discomfort and to deal with the stress. Because of these defense mechanisms arise from the unconscious, the person is unaware of using them. Some people overuse defense mechanisms which stops them from learning a variety of appropriate method to resolve anxiety. So this is a kind of lack of learning due to defense mechanisms which lead to anxiety disorder. The dependence on one or two defense mechanisms also can inhibit emotional growth, lead to poor problem solving skills, and create difficulty with relationships. In interpersonal theory, Harry Stax-Levin viewed anxiety as being generated from problems in interpersonal relationships, and caregivers can communicate anxiety to infant or children through inadequate nurturing, agitation when holding or handling the child, and distorted messaging. He want to say that the person um, get the anxiety from the behavior of their caregivers, how their caregivers dealt with the person, and that learning inculcated into the behavior of the patient and developed anxiety disorder. The behavioral theory says that the disorder are being learned through the experience of self, and the person is not able to unlearn the negative experiences, and behaviorists believe that the people can modify maladaptive behavior without gaining insight into their cause, and they contend that disturbing behavior that develop interfere with the person's life can be extinguished or unlearned by the repeated experience guided by a trained therapist. The person who have learned the uh, eccentric way of behaving is through the self-learning, and this cycle can be uh, break by the experienced trained therapist by process of unlearning the behavior or extinguishing of the behavioral pattern. In classification, there are phobic anxiety disorder as per ICD-10. Agoraphobia is there with or without panic disorder, social phobia, specific phobia, and generalized anxiety disorder. What does it mean? Agoraphobia is the fear of being in those places from where easy escape is not possible, like crowds, public place, traveling alone, traveling away from the home. In the situation from where easy escape is not possible, it is known as agoraphobia, and person usually avoid those situations. They avoid going to markets, they avoid traveling alone, they avoid going to the public places. And panic attacks means repeated acute intense attack of anxiety accompanied by feeling of impending doom is known as panic attack. Severe anxiety with the feeling of impending doom is panic attack. In social phobia, what happens is there is marked fear of being in the focus of attention and fear of behaving in a way that will be embarrassing or humiliating. Marked avoidance you will find in this person for social situation. They are feeling anxious in speaking to some unknown person and speaking to the public. They feel like anxious. In specific phobias, uh, these phobias are restricted to highly specific situation, like for particular animal, for height, for darkness, or flying. So these are the particular situation for which the person has phobias is known as specific phobia. Generalized anxiety disorder is anxiety which is generalized and persistent for almost all of the events happening around the person, and it is not restricted to any particular environmental circumstances. It is known as free floating anxiety. So again, the assessment, the history is important. The patient usually seek treatment for panic disorder after he or she experience several panic attacks. If it is repeated, the person may come for therapy, and they may report, I feel like I am going crazy and I thought I was having heart attack, but the doctor says it is anxiety. So this kind of history you will find. In motor behavior, uh, the client may appear entirely normal or may have signs of anxiety at the time of presentation. In mood and affect, they seems to be anxious, worried, tense, depressed, serious, or maybe sad. Comorbid depression is there. In thought process and content, during a panic attack, the person is overwhelmed, believing that he or she is dying, losing control, or going insane. Sensorium and intellectual process during the panic attack, the client may become confused or disoriented, he or she cannot take the environmental cues and respond appropriately, these functions are restored to normal after the panic attack is over, usually after 5 to 30 minutes of episode. In the treatment, various classes of drugs available for the anxiety disorders. The classes are tricyclic antidepressants, selective serotonin reuptake inhibitors, selective norepinephrine reuptake inhibitors, benzodiazepines like lorazepam, clonazepam, beta blockers like propranolol, buspirone, and low dose of antipsychotics are available to treat these persons. In non-pharmacological treatment, what one can do is can provide a safe environment and ensure the client's privacy during the panic attack, remain with the client during the whole panic attack, help the client focus on the deep breathing, which may relieve the attack early, take to the patient in a calm, reassuring voice, teach the patient to use relaxation technique at the time of panic attack, help the patient use cognitive restructuring techniques, that the cognitive distortion the person is having, that he is having certain kind of heart ailments or heart attack. So this is not cognitive structuring can be done for um, realigning the thought process. Engage the person to explore how to decrease stressor and anxiety provoking situations. The family education is also important. For panic disorder, review breathing control and relaxation techniques should be taught. Discuss positive coping strategies to combat the anxiety. Encourage regular exercise. Emphasize the importance of maintaining prescribed medication regular with the treatment and follow-up. Describe the time management technique, the to-do list, and basically structuring the daily routine is important. The other non-psychopharmacological treatment which are available for anxiety disorders are cognitive behavior therapy known as CBT, systematic desensitization, implosion, applied relaxation, respiratory exercise, and virtual reality therapy. So we are not going into detail of these treatment process, but one should know about them. And so for anxiety disorder, the key points in the last are: anxiety has positive and negative side effects. The negative effect produce poor self-esteem, fear, inhibition, and anxiety disorder. There are 4 levels of anxiety: mild, moderate, severe, and panic. Current etiologic theories and studies of anxiety disorder have shown a familial incidence of inheritance and had implicated the neurotransmitter GABA and serotonin. Treatment for anxiety disorder involves medications such as SSRI, tricyclic antidepressant, anxiolytics, clonidine, and propranolol. In a panic attack, the person feels as if he is dying. The person has a fight or freeze response. Phobias are excessive anxiety about being in the public place or open place like agoraphobia, or to a specific object or social situations. By these words, I am ending my lecture. Thank you.